Dear colleagues, in this presentation I would like to present a step-by-step approach for the clinical evaluation of shoulder pathology. 7 steps are used: history, inspection, palpation, passive motion, active motion against resistance, and a lidocaine test. These 7 steps will allow to make a clinical diagnosis in 90% of the cases in patients with shoulder pathology. The clinical test that will be used in a specific step will be defined by the examination in the previous step. This is the reason why it's important to start the examination with the evaluation of the passive motion before the active motion. Passive motion of the glenohumeral joint is checked in the cubitus dorsalis to exclude thoracoscapular motion and will be compared with the other side. The aim is to search for a structural lesion. As mentioned, interpretation of the active motion examination is dependent on the evaluation of the passive motion. For example, in a patient with frozen shoulder, passive motion will be limited, and as a consequence, also active motion will be limited. In a patient with an acute rotator cuff tear, passive motion can be normal, but active motion will be limited. Everything starts with the history of the patient. This is a very important moment in the consultation, not only because it will often help to orient the diagnosis, but also because it will enable the practitioner to gauge the patient's ability, his true impairment and his functional requirements. It will also help to break the ice, and a patient who is at ease is always easier to examine. First of all, concerning the pain. Pain caused by a structural lesion of the shoulder is generally a mechanical type of pain, increased by movement, particularly raising the arm, and relieved by rest. In patients where the pain is caused by movement or the neck, or if there is no correlation between the pain and shoulder movement, the shoulder may not be the origin of the pain. Next questions concern the severity of the pain. The more intense the pain, the more the pain irradiates and the more there is pain at rest. Also, an important question is the pain at night. Very often the patient is unable to sleep on the affected side. This can be the main reason for the consultation. The circumstances which trigger the pain is very evocative. Did the pain started after trauma, or is it a progressive onset? It's also important to ask for symptoms in other joints and to see if there are associated symptoms like fever and paresthesias. The patient have to be asked for chronic diseases, for example like diabetes and thyroid problems, because some shoulder pathologies are being seen more frequently in this group of patients. Also, evaluation of chronic medication like anticoagulantia is necessary, certainly when planning surgery. Next, the inspection. The patient ought to be exposed to the waist, and functional anatomy and biomechanical imbalance should be observed in the vertical position, from front and behind. Several bony and muscle landmarks can be seen. First of all, the clavicle. Is there a sign of clavicular malunion or status after surgery? Next, the AC joint, for example, an acute or chronic dislocation of the AC joint can be seen. Also, the contour of the shoulder need to be evaluated, and for example, a loss of contour can be seen in anterior shoulder dislocations. Muscle wasting of the deltoid can be seen in patients with a nervus axillaris lesion, or detachment of the deltoid after surgery. From the back, atrophy of the supraspinatus and/or infraspinatus can be seen in nervus suprascapularis lesion or chronic rotator cuff tears. The next step is palpation. First of all, the AC joint. Pain during palpation is mainly at the posterolateral corner of the AC joint, but the complete joint line needs to be palpated. Also, the SC joint can be palpated. Also, the AC joint needs to be palpated over the complete joint line. Several patients with the AC symptoms also have minor SC symptoms. During palpation of the long head of the biceps, it is necessary that the arm can rotate freely. The sulcus intertubercularis with the long head tendon can be felt between the minor and major tubercle. Palpation of the levator scapula needs to be done at the angulus superior of the scapula. During palpation, you can feel the tendon rolling under your fingers. Next, passive range of motion of the glenohumeral joint is checked on both sides. To measure the passive range of motion, the patient is in the supine position to exclude thoracoscapular motion. 4 rotations are checked: external and internal rotation in adduction and external and internal rotation in abduction. External rotation and adduction is performed by rotating the arm while pushing the upper arm against the body of the patient. Internal rotation and adduction is achieved by flexing the shoulder and elbow to 90 degrees, stabilizing the scapula and internally rotate the arm. Normally, an internal rotation can be achieved until the nipple line, and this movement is not painful. At last, the external and internal rotation is measured in 90 degrees of abduction while always stabilizing the scapula to exclude thoracoscapular motion. As discussed, these rotations need to be measured on both sides. In, for example, a frozen shoulder, there will be a lot of rotation in all four measurements, mainly in external rotation compared to the other side. Also, posterior capsule tightness can be seen while doing these four measurements. In this case, the external rotation in adduction and abduction is normal, but the internal rotation, mainly at abduction, is diminished left compared to the right side. Next, also the passive motion of the AC joint is checked. To perform the Drower's test, first the acromion needs to be stabilized. Next, the clavicle is fixed between the two fingers of the other hand and an anteroposterior motion is induced. This test is evaluating the pain and the laxity of the joint. Pain at the AC joint is also checked with cross-abduction test. The AC joint is stabilized with downward pressure and the arm is flexed and maximally adducted to induce a mechanical conflict. Pain sensation should be evaluated. The same test can be performed at the SC joint. The sternum is stabilized by a finger positioned in the notch, and with the other hand an anteroposterior instability is checked. The cross-adduction test, also described previously, can also be used to evaluate pain at the SC joint. If there is a suspicion of instability of the glenohumeral joint, next tests can be done while the patient is still supine. First of all, anterior instability is evaluated. The clinician abducts the arm to 90 degrees and passively brings it into external rotation. Anterior instability is strongly suggested if apprehension results or if the muscle spasm prevents further external rotation. This test seemed to be more positive by putting one hand beneath the spinous scapula. When apprehension is mentioned, the humeral head can be pushed posteriorly. If there is a relief of symptoms, this is a positive relocation test. It has been described that apprehension is more sensitive and specific for anterior instability than pain sensation and release. The load and shift test can be used to assess anterior and posterior laxity. It's important to perform this test in a completely relaxed arm. This can be achieved by fixing the hand of the patient underneath your axilla. Next, the scapula is stabilized and the humeral head is pushed forward. The degree of translation is assessed. Also, a posterior load of the humeral head can be performed and the shift can be measured. Posterior instability can be checked with the posterior apprehension test. The arm is flexed and internally rotated. Maximal adduction of the arm is achieved and a posterior pressure on the elbow is given. This test is positive if the patient has apprehension. A variation of this test is the jerk test. The patient's arm is abducted to 90 degrees and internally rotated. The examiner actually loads the humerus while the arm is moved horizontal across the body. In a positive test, there will be a sudden jerk as a humeral head slides off the back of the glenoid. When evaluating the glenohumeral instability, also inferior laxity need to be evaluated. First of all, the sulcus sign. In patients with inferior laxity, an indentation on the acromion can be seen when the arm is pulled downwards while torso movement is prevented. Another test is the test of Gaget. During the test of Gaget, the examiner holds the shoulder girdle firmly in a lower position and with the other hands lift the arms up in the frontal plane. A range of passive adduction of more than 105 degrees is associated with lengthening and laxity of the inferior glenohumeral ligament. This test can also induce apprehension and can be an indication for inferior instability. As like all other tests, both sides need to be evaluated. After evaluation of the passive motion and laxity of the shoulder, active motion is evaluated. First of all, normal active range of motion of the neck with flexion, extension, rotation and lateral flexion is asked. Pain and loss of motion is evaluated. Next, thoracoScapular motion is evaluated with elevation, depression, retraction, and protraction. At last, active motion of the complete shoulder girdle is evaluated. 4 active motion of the shoulder girdle are measured: flexion, abduction, internal rotation, and external rotation. These 4 motions can also be used during the evaluation of the function of the shoulder with the constant Murley score. During internal rotation, it's important to check the patient is not using his pathological arm to help to achieve a better internal rotation. For example, this patient has an active pain-free flexion of 90 degrees, active pain-free abduction of 70 degrees, active internal rotation until D12, and no active external rotation. During active flexion and abduction, also scapular dyskinesia need to be evaluated. Scapular dyskinesia is a general term that is used to describe loss of control of normal scapular physiology. 3 subtypes have been described. This is a video of a type 1. This girl has a prominent inferior medial border of the right scapula. This becomes more evident in the cocking position of overhead sports. It's often associated with tightness at the anterior side and weakness of the lower trapezius and serratus anterior muscles. This is a video of a type 2. This girl has a prominent complete medial border of her left scapula. It becomes more prominent in the cocking position and after repetitive elevation of the upper extremity. It's caused by fatigue of the scapular stabilizing muscles. Last, there is a type 3. This girl has a prominent supremedial border of her left scapula. Prominence of the supremedial border is often associated with impingement and rotator cuff injuries. After evaluating the active motion, several muscles can be tested using active motion against resistance. The anterior deltoid can be checked by performing an anteflexion of the arm against resistance. To evaluate the pars posterior of the musculus deltoideus, active retroflexion of the arm against resistance need to be done. Several tests have been described to analyze the involvement of the long head of the biceps. None of these tests are pathognomonic, but can help you in the differential diagnosis. The biceps is a supinator and a flexor of the upper arm, and these aspects are used in the different tests. First of all, the speed test. With anteflexion of the shoulder, extension of the elbow and supination of the arm, an active flexion of the elbow against resistance is performed. This test is positive if this induces pain in the region of the sulcus intertrabecularis. The Jurgensen test is focusing more on the supination function of the biceps. In a pronated and flexed elbow, supination of the forearm is performed against resistance. As in the speed test, this test is positive if this induces pain in the region of the sulcus intertrabecularis. Next tests are focusing on the stretching of the biceps, in pro and supination. First of all, the bicep stretching. When during passive external rotation there is less pain in supination than in pronation, the test is called positive. In pronation, the long head of the biceps is elongated, and if there is a pathology, extra stretching can be painful. Because of the locking mechanism of the biceps, you can see that the external rotation of the shoulder is less in an elongated stressed biceps in pronation compared to supination. This is a normal situation. During the O'Brien test, the flexed arm is adducted 10 to 20 degrees and active flexion is first performed with a pronated forearm and next in a supinated forearm. If there is pain during the first movement and if the pain diminished when the test is performed in supination, the test is called positive. Evaluation of the separate rotator cuff muscles can be hard because no test can completely isolate the muscles. This is particularly true for the evaluation of the supraspinatus. Supraspinatus is tested during active motion against resistance at 90 degrees of abduction in the scapular plane. During the full can test, the arm is externally rotated, and during the empty can, internally rotated. During the test, you should mainly focus on weakness and not on pain to evaluate supraspinatus pathology. It has been described that the anti-cam test is a little bit more sensitive to evaluate supraspinatus weakness. The strength can also be quantified and is used in the constant Murley score. Again, evaluation is done at 90 degrees in the scapular plane with an internally rotated arm. Next, infraspinatus and teres minor can be tested by performing external rotation against resistance. During the first test, the elbow is flexed to 90 degrees and the arm is brought in external rotation. First, it is checked if the patient can hold this position. Next, external rotation is attempted while the examiner actively resists this by holding the elbow to the patient's side. This test can also be performed in abduction of the arm. In this position, the teres minor is more active. This patient is unable to hold her arm in external rotation and adduction. She is also not able to hold her arm in external rotation and abduction. These signs are seen in patients with infraspinatus and teres minor insufficiency. Next, the subscapularis tendon. The first test is the Gerber test. The patient places his arm on the lower back with the palms facing outwards. This removes the influence of the pectoralis major and simply lifts the arm away from the body. If the patient is unable to lift the arm or hold the arm away from the body, this is called a positive Gerber test and it's indicative for subscapularis insufficiency. This test was modified by Gertel using the name internal rotational lag sign. It's carried out by placing the patient's hand at a distance from the lumbar region, elbow bent, and asking the patient to hold this position. Full return of the hand is a sign of a full tear, a limited return of the hand indicating a tear in the upper portion of the subscapularis. Thus modified, this test is thought to be more sensitive and its diagnostic precision greater, but the specificity is identical. The belly press test, also called the Napoleon's test, was suggested to test the subscapularis in patients with limited internal rotation. The patient, whose hand is placed on the stomach, wrist straight and elbow detached from the chest, is asked to press strongly onto the stomach with the hand while keeping the forearm in line with the hand and the detached elbow. This test can be more sensitive if this is performed against resistance. This test is positive and means a tear in the subscapularis when a patient who tries to press onto his stomach cannot maintain his elbow forward or can only exercise abdominal pressure by retropulsion of the arm and by bending the wrist. At last, a diagnostic infiltration of a specific space on the shoulder can help in the evaluation of shoulder pathology. The glenohumeral joint is most easily accessible with the patient sitting, the patient's arm resting comfortably at his side, and the shoulder externally rotated. Essential landmarks to palpate before performing this injection include the head of the humerus, the coracoid process, and the acromion. Using an aseptic technique, the needle should be placed just underneath and in the middle of the finger, positioned on the anterior acromion and the coracoid. The needle is directed posteriorly, inferiorly, and medially. If the needle hits against bone, it should be pulled back and redirected at a slightly different angle. There should be no resistance when performing this infiltration. To infiltrate the subacromial bursa, the posterior and anterior border of the acromion is palpated. Using an aseptic technique, the needle should be placed 1 or 2 centimeters underneath the middle of the acromion and angulated underneath the anterior part of the acromion. This is the location of the subacromial bursa. Also in this situation, there should be no resistance when performing this infiltration. To identify the AC joint, palpate the clavicle distally to its termination, at which point a slight depression will be felt at the joint articulation. A septic technique is followed. The needle is inserted from the superior and anterior approach into the AC joint and directed inferior. The lidocaine is injected evenly and slowly. At last, also an infiltration of the sternoclavicular joint can be performed. Identify the sternoclavicular joint and palpate the clavicle immediately to its termination, at which point a slight depression will be felt at the joint articulation. The needle is inserted from the anterior approach into the sternoclavicular joint and is directed posteromedially. The lidocaine is injected evenly and slowly. With this step-by-step approach, a clinical diagnosis in 90% of the patients with shoulder pathology is possible. Good luck.